So what we've talked about so far with this is that the spironolactone and eplerenone, they are better for blood pressure control. So if you're at the point where you're thinking about adding a mineral, an MRA, let's say, whether it's non-steroidal like finerenone or one of the older MRAs, if blood pressure is your tiebreaker, you might go with the older agents. But if it's just if you're just trying to reduce that albuminuria, you might go with the finerenone in that case, knowing that hyperkalemia could be an issue. Dr. Cohen, Jordy Cohen, gave us, patient CKD4. She's comfortable if it's a stable potassium up to 5.5. Joel, do you have a threshold for when you would stop one of these agents? Like if they go above 5.2, they go above 5.5, where do you set that threshold?
If I see that little H next to the potassium, I kind of feel the need to intervene.
Oh, good. Me too.
I've become a lot less brave as my career has progressed, because it doesn't take many calls in the middle of the night of a patient saying, "Hey, my primary care doctor just called me and told me to go to the emergency medicine," or excuse me, it doesn't take many calls in the middle of the night for your patient says, "My primary care just called me, told me to go to the emergency room because my potassium is too high. And the emergency room said it was because of the drugs you prescribed." Right. Right. And going to the emergency room in the middle of the night, like being told that you have a critical lab value that you need to go to the ER, is a terrifying thing for patients. Right. That's a traumatic experience that I don't want anybody to go through. And so, do I think anybody's going to die of a cardiac arrest with a potassium of 5.5? No, I don't. I think they're probably fine with it, but they still make, if that's their floor, it's going to go up and down there, and it might go up. Yeah. It might go to 6. And other doctors are going to tell them things that you may not have, and it's not unreasonable. I'm not saying that the family practitioner is wrong or the primary care doctor is wrong to do that, but it is, and you don't want that to happen to your patient. And so, I just kind of look at what's the advantage of these drugs. These drugs are they're working on the margins, right? They're over 5 years is a 15% reduction of this composite outcome versus, I had to go to the emergency room in the middle of the night. I try to avoid that as much as possible. And so I think I'm probably a little less brave than Jordy. I do see, once you get to CKD stage 4 and you start slinging those mineralocorticoid antagonists, hyperkalemia is a real issue. And I do it, but I'm careful about it and I'm a little reluctant to it. And I talk to patients about the risk because it happens. Again, it's not so much that they're dying of cardiac arrest, but they do get hyperkalemia.
So, Paul, I don't know. Are you seeing patients on potassium binders to try to, I imagine they're being used to try to continue medications. Are you seeing that? I've been seeing a fair amount of that in the past few years.
I think a fair amount would be an overstatement, but I do see it often enough, certainly more than I used to. Where it's just the idea that these medications have enough benefit that it's worth adding another medication to control the side effects of the first medication that you added on. So yes is my long-winded answer.
And I think the last time we talked about this, Joel, with you was during a Neph Madness, we talked about hyperkalemia a few years ago. And where has practice gone in the past 2 years with that? Are people finding the benefit of adding these, there's SCC, SPS, patirimer, there's all these binders. Can you talk to us about that?
Yeah. So the traditional binder was sodium polystyrene sulfate.
Something.
This
SPS.
was SPS. The trade name was Kionex or Kayexalate. And this drug tastes terrible, gives patients pretty bad diarrhea and GI upset. Patients hate taking it. And then there's 2 new binders that are really tasteless and easily tolerable for pretty long periods. There's one that's sodium zirconium cyclosilicate.
Sorry, Joel, carry on.
Sodium zirconium cyclosilicate, which trade name is Localma. And then there's Patiramir, which is the trade name Veltessa. And again, both pretty well tolerated, both work well to lower the potassium. And they've definitely been marketed as drugs that allow you to keep patients on these RAS inhibition. So my first question, Matt, I'm really curious. Have you been seeing this come from cardiologists or from nephrologists? Is it people with heart failure, or are you seeing it patients that have chronic kidney disease?
I have a couple patients with chronic kidney disease that I have seen on this. And I imagine it's because in some cases, I think it's just they're just hyperkalemic from their chronic kidney disease, and it's not necessarily, they're not saying we're doing this to try to keep them on their valsartan or whatever. I think it's just hyperkalemia.
Yeah, I have a few patients, and the reason I ask is because I think the effectiveness of ACE inhibition in advanced heart failure is incredibly dramatic, right? These are patients that otherwise would have months to live, and you can really extend it out, right? Mm-hmm. And I think about what patients go through to get an equivalent kind of survival benefit for cancer, and they will go through incredible side effects. Yep. And this is way less than that. And so for advanced heart failure, I think it's a no-brainer. If this is what it takes for them to stay on their ACE inhibitor, I would start it in a minute. And then another patient I'm thinking of has really difficult to control hypertension, and their blood pressure comes right in line with a spironolactone, mineralocorticoid receptor antagonist, Spiro. But they have hyperkalemia with that. And I can't get their blood pressure controlled otherwise. And so I went with potassium binder in that situation. Kind of felt like this was an easy call. And then after that, it's kind of been a few cases here and there. Patients that are particularly motivated, that are really kind of pushing me. Is there anything else we can do? Is there anything else we can do? And I was like, well, we could, they had already been intolerant to ACE inhibitors before. And I was like, well, we can get you back on an ACE inhibitor if we use something to monitor the potassium. And I've actually been surprised. Like, it doesn't take a binder every day. It doesn't take patiromer every day. I usually can get by with 3 doses a week. Not always. It varies from patient to patient. And these are patients with GFRs. Typically, they were in less than 20. And for me, I've been doing it when I can't get them on like kind of that first level therapy, right? I can't even get them on an ACE inhibitor otherwise. And so I'm doing that. And then the other people that I use on is I have patients that are super reluctant to start dialysis and probably will never start dialysis. And so I'm facing patients with GFRs less than 10 that want conservative care. And so, okay, we're going to monitor. This is one thing that could off you is hyperkalemia. Okay, we'll use a drug here to prevent that. And there's no ACE inhibitor in sight in those patients. We're already trying to avoid that completely.